All right. Hello, everyone. So we are going to discuss some recall questions as far as this year's NEET SS Pediatrics was concerned. So just before I start discussing the actual questions, just a brief overview. I think all you guys have already discussed it a lot. Definitely this year's papers as compared to other year papers were a little tougher. There's no denying that. Having said that, I feel that the difficulty level just after the exams, you guys probably overestimated the difficulty. Maybe once you're going through the recalls, you probably will realize maybe you made some silly mistakes or you did some, there were some, okay, like silly recall errors that you made. But there was a significant trend. I would say that there was still a lot of questions which were actually previous year questions or previous year question repeat. Like, very, very similar to what the questions had been asked in the last year NEET SS or the last year NEET SS. I'll in fact start with the first question. That is like it might seem like a new question, but it's something which has been asked again and again, something which we have discussed in Elite again and again, right? And as we discuss these questions, around 20 questions we'll discuss today. I'll keep on saying that how we have discussed these two questions as far as our doc tutorials videos and as far as our Elite sessions were concerned. So if you're regular with your QBank practice, if you're regular with the videos of the doc tutorials, and if you're regular with the Elite test series, again, I'm emphasizing a lot of these questions, when I was going through the recalls, I realized that a lot of these questions, at least 40-50% of these questions, we had discussed those topics and similar questions, if not the exact question, in the Elite Test series. Again, emphasizing the importance of that. All right. Now, on that note, let's start with the discussion. So, first question, which I'm going to discuss, which of the amongst the following is correct regarding transient abnormal myelopoiesis in Down syndrome? So, again, although this is not exactly a previous year question, I would call it a previous year topic repeat. Like Down syndrome and leukemia, as far as Down syndrome and leukemia is concerned, it's been this is a thrice, like, in 2023, 24, 20, like if you consider this 20 last year's as 24. So 3 continuous years they have asked about Down syndrome and they have asked about Down syndrome and leukemia related to Down syndromes. Again and again, this is a trend that they are asking again and again. All right. So let's go by option one by one. And in the Elite also, we had discussed questions related to Down syndrome and leukemia. We had discussed questions related to Down syndrome and leukemia. TAM is rare, not seen in children below 3 years of age. So this is incorrect, right? The question is asking if the following is a correct statement. So this first statement is an incorrect statement. Remember, first statement is an incorrect statement. So TAM is decently common, right? It's not that it's not common. And more importantly, TAM is seen when? When is TAM seen? TAM is seen in a newborn. TAM is seen transient abnormal myelopoiesis, which is also sometimes called, now actually TAM is a wrong terminology nowadays. Nowadays it's called transient leukemia or Down syndrome. Nowadays it's actually called as transient leukemia or Down syndrome, right? And it's seen when? It's seen in a newborn period, right? When newborn will suddenly have counts like 50,000, 70,000, 1 lakh. And most of the times these are myeloid blasts, but they tend to regress in most cases. Not in all cases, but in some cases, yes. ALL is the most common type in these and it occurs below 3 years of age. This is false. Like I said, these blasts are what? They're myeloid blasts. It's AML. If it has to progress, it will progress into AML. Transient myelopoiesis might progress to future leukemia. This is true, and hence the correct answer to this statement. The correct answer to this question will be option C. Yes, there is a chance, around 20-25% chances there that transient myelopoiesis of child who had TAM later in life will transform into what? Usually they transform into what? They transform into AML. They transform into AML. Chemotherapy is required for all cases? No. This is also not true. Only if LTS, what is LTS? Only if life-threatening symptoms are there, then do you do chemotherapy. And what kind of chemotherapy? Mild chemotherapy, which gives subcutaneous cytosine or rabinocyte. We give what? We give subcutaneous Arasi. We give subcutaneous Arasi. We give subcutaneous Arasi. That's it. Nothing extraordinary. We don't give Daunorubicin plus Arasi as a 7+3 regimen like that. No, that's not given as far as TAM is concerned or transient leukemia or Down syndrome is concerned. So the answer here is going to be option C will be the correct answer. Option C will be the correct answer. All right. So a little bit about Downs and leukemia, because this is something which is being asked so frequently, right? So anyone who's just watching this call, even if you're not a subscriber to doc tutorials, you will definitely benefit from this particular table. And so remember, in Down syndrome, the overall most common leukemia is actually ALL. ALL is more common than AML in a 60:40 ratio, or sometimes called 2:1 ratio, right? In fact, that's the line which is given as far as Nelson is concerned, that in Down syndrome, the frequency of leukemia is same as that of other childhood, which basically means that normally in childhood, ALL is more common than AML. In Down syndrome also, ALL is more common than AML. But, and this is an important but, on which they are keep on asking questions again and again. In less than 3 year, AML is more common than ALL. And in more than 3 year, ALL is more common than AML. And overall, as I have discussed, ALL is more common as compared to AML, right? Overall, ALL is more common as compared to ML. So this is the thing. This is what we had asked. That's why this option B is incorrect. ALL is not the most common. It is AML which is the most common. And TAM also converts into AML. If it has to convert, it will convert into AML. Now, why does TAM occur? TAM occurs because of GATA1 mutations. It occurs because of GATA1 mutations. It occurs because of GATA1 mutation, and only if life-threatening symptoms are there, then only we give chemotherapy. Otherwise, no. Otherwise, we do what? If life-threatening symptoms are absent, we do what? We just do observation. That's it. Nothing else is required, right? As far as prognosis is concerned, as compared to normal children, remember, in down, AML has better prognosis as compared to normal childhood, while ALL has worse prognosis. So a normal child having AML, a Down syndrome kid having AML, a Down syndrome kid having AML has better prognosis. A normal kid having ALL, a Down syndrome kid having ALL. The Down syndrome kid with ALL will have worse prognosis as compared to a normal kid having ALL, right? So this thing again, this is something which they love to ask again and again, that AML has better prognosis in down, well, ALL has worse prognosis as far as down is concerned. All right, as far as down is concerned. Let's move on to the next question. A child presented with severe bony pain on X-ray. There was a diaphyseal tumor. Which tumor? Diaphyseal tumor. So remember that as far as bone tumors are concerned, there are only two tumors in children which you should know about. One is your osteogenic sarcoma, that is osteosarcoma. Other is your Ewing sarcoma. Now, osteogenic sarcoma is a metaphyseal tumor. You will see it at where? You will see it at metaphysis. It's a metaphyseal, while Ewing sarcoma is a diaphyseal tumor. So even with this information, you know this is Ewing sarcoma. Even with this information, you should know it's Ewing sarcoma. They had also given onion peeling. Onion peeling confirms this is Ewing sarcoma. Onion peeling is something which is characteristic seen as far as X-ray of Ewing sarcoma is concerned. So onion peeling and a diaphyseal tumor confirms this is what? This is Ewing sarcoma. What is the expected cytogenetic abnormality? So they are asking which mutation is seen. So we all know translocation 1122 is the one which is seen as far as Ewing sarcoma is concerned. Hence, option A will be the correct answer. Option A is going to be the correct answer. So this is how on X-ray Ewing's is going to look like. You can see you can actually make out this is a what? This is a diaphyseal tumor, right? If I make a long bone like this, I'm going to make a long bone like this. Ewings will occur in this area. Ewings will occur in this diaphyseal area. It will occur in the diaphyseal area. Well, as far as osteogenic sarcoma is concerned, where will it occur? It will occur in this area. It will occur at the metaphyseal end. Right? It will occur at the metaphyseal. So you can see this tumor is here in the diaphyseal area, and you can see the onion peeling. You can see the characteristic onion peeling, right? And like I said, the translocation is translocation 1122, EWSR1 with FL1. FLI1. So that's a very characteristic translocation, and this is a repeat question. This is a repeat PYQ. All right. We move to the next question. All of the following are causes of macrocephaly except Tay-Sachs. So Tay-Sachs is a lysosomal storage disorder, right? Phenylketonuria. Phenylketonuria is an inborn error of metabolism where there's a problem in phenylalanine hydroxylase, where there is a deficiency of phenylalanine hydroxylase. Canavan and Alexander disease, both are examples of leukodystrophies. So which of the following doesn't have microcephaly? So the answer here is going to be option B, phenylketonuria. Phenylketonuria has what? Phenylketonuria actually has, it has microcephaly. Now, as far as causes of macro and microcephaly are concerned, you can simply remember them by this mnemonic. So macrocephaly, the causes are what are called as, I like to call as 3H, 2L, 1S, and 1N. What are these 3H's? These are your hemorrhage, anything that causes hydrocephalus, So your Arnold-Chiari malformation, vein of Gallen malformation, Danny-Walker malformation, anything that can cause hydrocephalus, tumors, they will cause macrocephaly, and hydranencephaly. Then lysosomal storage disorders and leukodystrophies have macrocephaly. SOTOS has macrocephaly, and neurocutaneous syndromes in general have macrocephaly. So these are causes of macrocephaly. Coming to microcephaly, what are the causes of microcephaly? You can remember it by the mnemonic getting shot. Right? In microcephaly, your head size, your brain's head circumference getting short, right? What are these? There are genetic causes. Basically, by genetic, I basically means aneuploidies, like Down syndrome, Edward, Edward, and Patau, all these will have microcephaly, right? Then endocrine, as far as endo is concerned, the one which you all know is congenital hypothyroidism. Then any TORCH group of infection, like Zika, Toxo, Rubella, all of them can cause microcephaly. CMV can cause microcephaly. Then teratogens. So we all know alcohol, fetal alcohol syndrome, fetal phenytoin syndrome, and I stands for inborn error of metabolism. So inborn error of metabolism, like phenylketonuria, galactosemia, like PKU, galactosemia, all of them can end up having microcephaly. And the last, this N stands for neural tube defects. So anencephaly, obviously, the head circumference is 0, right? So N is neural tube defects. And S is structural problems like lysencephaly, schizencephaly, the neuronal migration defects, which can also have microcephaly. So it's a very simple mnemonic by which you can run, they're simple, these are simple questions, but they do come in the exam as far as NEET SS is concerned. All right. Let's move on to the next question. Thrombocytopenia is classically seen with which type of von Willebrand disease? So we had discussed this in the von Willebrand video. We had actually discussed this and we had given a one-liner also. So this is a screenshot from that video where I had specifically said that in type 2B, there is what? Increased binding to platelet. There is increased binding to platelet of von Willebrand factor and platelet. And then it is cleared. This binding to platelet and clearing of this platelet von Willebrand factor results in fall in platelet and hence thrombocytopenia. So answer here is going to be option 2B. That is option C, right? Type 2B is the one which is associated with a fall in platelet count. So we discussed this in the videos. If you had gone through the videos, if you had gone through the notes, you would have gotten this correct. Mostly you would have gotten this correct. Mostly you would have gotten this correct. Next, a child is incidentally found to have horseshoe kidney on imaging. Which of the following statement is correct regarding the anatomical fusion? Fusion of upper poles of kidney? No. Fusion of lower poles of kidney? Yes. The answer is going to be option B. Answer is going to be option B. So what is renal horseshoe kidney? Horseshoe kidney is nothing but your renal fusion anomaly, where there is a fusion of what? There's a fusion of lower pole of kidney. Remember, horseshoe kidney is associated with Turner syndrome. It is associated with Edward syndrome. Edward has horseshoe kidney. Patau has P for Patau, P for polycystic kidney. And in horseshoe kidney, this characteristically an increased risk of having Wilms tumor. And usually there is a fusion at the lower pole. See, this is the lower pole. This is the lower pole of kidney. That's where it's fused, resulting in a horseshoe or a U-shaped structure. Remember, in horseshoe kidney, it's a lower pole which is fused, and it's associated with increased risk of recurrent UTIs and reflux nephropathy. All right. So this is as far as renal fusion anomaly or horseshoe kidney is concerned. We have discussed this in the videos. All right. Moving to the next one. An exclusively breastfed infant presents receiving additional bovine milk supplementation. Presents with blood stools and rectal ulcer on evaluation. The infant is otherwise thriving and systemic examination is normal. What is the most appropriate feeding management? Why are you giving this bovine milk? All right. Why are you giving this bovine milk? Right. There's no need for giving this bovine milk. Just give mother's milk. Just give mother's milk. Right. Just give mother's milk. So answer will be, this is essentially cow milk protein allergy. This is essentially cow milk protein allergy. This is essentially exclusively breastfeed the baby. You need to exclusively breastfeed the baby. That's going to be the answer, right? You need to exclusively breastfeed the baby. All right, moving to the next question. A child has macroorchidism, intellectual disability, and long face. So intellectual disability plus long face, there is only, and big testes. This is your fragile X chromosome disorder. This is your fragile X. So in Klinefelter, what's going to be there? Will there be a long face? No, there are long limbs. Klinefelter has long limbs. It has long limbs. Prader-Willi has hypogonadism. Macroni, microtestes are there. It has hypogonadism. It has hypogonadism. Angelman, they haven't given any history of the happy puppet with happy, inappropriate laughter ataxia like this. So this is how fragile X chromosome looks like. You can see the abnormally long face. You can see the abnormally long face, right? They tend to have these protruding ears. They tend to have these protruding ears, right? They tend to have large protruding ears, a prominent lower jaw. The lower jaw is very prominent. This is very characteristic as far as your fragile X chromosome disorder is concerned. Fragile X chromosome disorder is concerned. All right. Next question. A 3-year-old child, a 3-year-old child has presented with recurrent UTIs. All right. There is bilateral hydronephrosis, USG showing mild pelvic calcial dilatation. What is the most appropriate next investigation to confirm the suspected diagnosis? So this is pointing towards what? This is pointing towards VUR, and investigation of choice of VUR is MCUG. Right? Even if you are not able to get to the diagnosis, what do we do in recurrent UTIs? Whenever there is recurrent UTIs, the first investigation is ultrasound, which they have already done. After ultrasound, you do what? You do an MCUG. You do an MCUG. This is a flowchart from the recent ISPN guidelines, right? When you have a UTI, whenever you have confirmed UTI, after an ultrasound, you have to go for what? After an ultrasound, if it's abnormal, you have to go for MCU study. You have to go for MCUG, and then you have to go for a DMSA. So the answer here is going to be what? It's going to be MCUG. DMSA is after that, right? DMSA is after that. Anyways, we are suspecting what? Anyways, we are suspecting VUR in this particular case. We have to do an MCUG. All right. Next question. A child presented with polyuria with ABC showing metabolic alkalosis and also having hypokalemia, hypomagnesemia. So hypokalemia, hypomagnesemia plus metabolic alkalosis, all this is pointing towards what? This is Gentleman. And remember, Gentleman is inherited in a autosomal recessive manner, right? Autosomal dominant would happen little. Autosomal dominant would happen little. Polygenic is essential hypertension, that is primary hypertension, right? So primary hypertension is usually polygenic in nature, right? And this is Gentleman and Barter, they tend to have autosomal recessive. So answer is going to be option C. Option C is the correct answer. Option C is the correct answer because this is resembling what? This is resembling Gentleman. Gentleman is autosomal recessive. All right. Next question. A girl presents with recurrent gross hematuria indicating IgA nephropathy. Which of the following indicate poor prognosis with risk of progression to ESRT? Right. So remember in IgA nephropathy, what do we give? Even if you didn't remember anything, remember, what do we give? We give ACE inhibitors. And why do we give ACE inhibitors? Because they decrease the risk of proteinuria. They decrease proteinuria. ACE inhibitors will reduce the GFR. That will reduce the proteinuria. And why do we want to reduce proteinuria? Because proteinuria is the single most important factor that determines whether you progress to end-stage renal disease or not. So the answer to this question is going to be high proteinuria. Some people have said proteinuria more than 1 gram, which is again high proteinuria only, right? Some people had recalled that. So yeah, so this is going to be the one. IgA nephropathy, what indicates poor prognosis? A high amount of proteinuria. A high amount of proteinuria. Now, degree of cyanosis in TOF correlates with, we have discussed this in the videos also. If I make a diagram of TOF, remember, everything in TOF starts from pulmonary stenosis, which is your right ventricular high flow tract obstruction. More the pulmonary stenosis, more will be the right ventricular hypertrophy. If there is pulmonary stenosis, this will lead to right ventricular hypertrophy. More the right ventricular hypertrophy, more the blood will shunt from right to left, resulting in more cyanosis. So degree of cyanosis in tetralogy of Arrett is dependent upon pulmonary stenosis. More the pulmonary stenosis, more the right ventricle contracts harder, more it is less able to send into the pulmonary artery or in the pulmonary trunk, the lungs, and more there is right to left shunt. So cyanosis, remember, is directly proportional to the amount of pulmonary stenosis, that is your RVOT, right ventricular outflow tract obstruction. So answer is going to be option B. Answer is going to be option B. A preterm neonate has recurrent apneic episodes. Obstructive causes are ruled out. This is what? This is apnea prematurity. What is the next step? Drug of choice is caffeine. Drug of choice is caffeine. So I discussed this, right? If there are frequent episodes, of apnea, what we have to do, this is a screenshot from the videos. We have to give what? We have to give caffeine. We have to give caffeine. Only if caffeine fails, then we give CPAP and we move towards ventilation. But first we have to give a trial of caffeine. All right. Next question. A 45-day-old infant presents with jaundice since birth. There is pale stools and dark urine. Child is otherwise stable, means child is not sick, and this is very important. Not sick child, pale stools, and neonatal jaundice. This is what? Neonatal cholestasis with non-sick child. You are going towards EHBA. What is the first investigation that you do? So you first start with ultrasound, and then if your ultrasound is suggestive of EHBA, you do a biopsy. Right? So the answer is going to be ultrasound. And this is the algorithm. A child has come to you with neonatal cholestasis. Child is not sick. And here they have given child is stable. Right? Child is having pale stools. The next thing that you do is you do an ultrasound. You do what? You do an ultrasound. Right? Remember, HIDA is a obsolete investigation nowadays. A 2-year-old child presents with poor weight gain, developmental delay. Examination shows wide mouth, full lips. Examination shows what? It shows wide mouth, full lips. Blood investigation show hypercalcemia and supravalvular aortic stenosis. See, supravalvular aortic stenosis. This is so characteristic of Wilms tumor, and they love asking this question. Supravalvular aortic stenosis means Wilms syndrome. Means with what? Wilms syndrome. It means Wilms syndrome. 7q11 deletion. 7q11 micro deletion. 7q11. There is a 7q11 micro deletion. So this is how Wilms syndrome looks like. This is how Wilms syndrome looks like. You can see a long forehead, long philtrum, a puffy face. All these things together are called as what? They're called as the elfin facies, right? So which they have given here as wide mouth, full lips, right? So big mouth, a puffy mouth, right? So they are giving you what? They were giving you elfin facies. Plus the hypercalcemia. The hypercalcemia also is pointing towards what? Wilms syndrome, Wilms syndrome. Digeorge will have what? It will have decrease in calcium. Beckwith-Wiedemann syndrome will have hemihypertrophy. Prader-Willi will have hypogonadism. It will have hypogonadism, right? So these are the things, and this is how you can end up getting to the answer. Now, a child presented with headache and features suggestive of raised ICP. There was posterior fossa tumor. There is what? There is a posterior fossa tumor. There is a posterior fossa tumor and tumor cells in CSF. Means there is metastasis into the CSF. This is going to be what? This is going to be your medulloblastoma. Medulloblastoma, anyways, is the most common posterior fossa tumor. And from that also, you can directly make the diagnosis. It's going to be medulloblastoma. A child presented at 8 months of age. A child presented at 8 months of age with CCF and cyanosis. So this is a cyanotic congenital heart disease with CCF. CCF means that for CCF to occur, there has to be increased pulmonary blood flow. For CCF to occur, there has to be increased pulmonary blood flow. So you have increased pulmonary blood flow with CCF. You have increased pulmonary blood flow with CCF. CCF means there is increased pulmonary blood flow and cyanotic congenital heart disease. So from this itself, ECG shows right axis deviation. All right. So tricuspid atresia has decreased pulmonary blood flow. So it will not have congestive cardiac failure. And more importantly, there is left axis deviation in tricuspid atresia. So this is ruled out, right? Then AVSD. As far as AVSD is concerned, AVSD is a acyanotic congenital heart disease. It's a acyanotic. So again, AVSD is ruled out. Now, between DTG and TAPVC, both are cyanotic heart diseases with increased pulmonary blood flow and can have CCF. The answer was here. There is a holosystolic murmur at the apex. There is a holosystolic murmur at the apex. Where is holosystolic murmur at apex seen? Characteristically, it is seen in VSD. It is seen in VSD, right? Is VSD a component of TAPVC or TGA? TGA we all know is of two types. TGA you can have with VSD. TGA you can have without VSD, right? Without VSD. While as far as TAPVC is concerned, usually they have a atrial septal defect, not ventricular septal defect. So the fact that they have given you a holosystolic murmur at apex means that they are telling you that there is a VSD, and VSD automatically means, right, it's going to be TGA. TGA is going to be the better answer. TGA will be the better answer. TGA is going to be the better answer. What differentiates APERT from Cruzon? So remember APERT and Cruzon, I like to think of them basically as big and smaller brother. Cruzon is the smaller brother. APERT is the bigger brother. APERT is the bigger brother. APERT is the bigger brother, right? Cruzon occurs because of FGFR2 gene mutations, autosomal dominant. APERT also occurs autosomal dominant and the same FGFR2 gene mutation. But just the manifestation is a little more severe as far as APERT is concerned. So Cruzon has craniosynostosis, APERT also has craniosynostosis, both are craniosynostosis syndrome. So can you use it to differentiate? No. Midline hyperplasia is present in both. Usually in Cruzon, there is only midline hyperplasia. In APERT, there's going to be what? In APERT, there is also going to be cleft lip and cleft palate. But by itself, is midline hyperplasia able to differentiate? The answer is no. Syndactyly, yes. Remember, syndactyly is a severe form, right? When the fingers are fused, the mitten hands, it's seen only, syndactyly is seen only in APERT. Syndactyly is seen only in APERT. It is not seen in Cruzon. It's not seen in Cruzon. It's not seen in Cruzon. Next question. A child comes to you with recurrent ear discharge and a scalp swelling. There is seborrheic dermatitis. Skull radiograph shows punched out lytic lesions. LCH is suspected, which the following is the most diagnostic. For LCH, you have to do what? You have to do a biopsy. Biopsy has to show you positivity for histiocytic markers. What are the histiocytic markers? You can be positive for CD1A, you can be positive for Langerin, you can be which is basically CD207, you can be positive for basically what? S100. These are the three things that you can be positive for, right? So which of the following is the most diagnostic? CD3 positivity? No. CD3 is positive in what? It's positive in, it's a T cell marker. It's a T cell marker. It will be positive in TLL or T lymphoblastic leukemia. Bone marrow biopsy showing histiocytic infiltration? No. See, here they have not given you anything related to bone marrow involvement. They have not given you pancytopenia. And more importantly, bone marrow biopsy, while it can be done, it's not like it's not really done, not done as far as LCH is concerned. But bone marrow biopsy with only with histiocytic infiltration is not characteristic of LCH only. That histiocytic infiltration can be seen in HLH also. It can be seen in other histiocytic disorders also. So again, this is not the answer. This is not the answer. CD20 positivity is seen where? CD20 positivity is seen in B cell neoplasm. It's seen in B cell neoplasms. So again, that is not the correct answer. Answer is going to be CD1A positivity. Answer is going to be CD1A positivity. Option C is going to be the correct answer. It's going to be the correct answer. We move on to the next question. A child with previous child had neural tube defect. What will you receive as preventive therapy? So remember, to prevent neural tube defect, we give folic acid. We give what? Folic acid. The normal dose for folic acid is 0.4 mg and it started 1 month prior, periconceptual. But if there is a previous pregnancy, the dose becomes 10x. That is 4 mg. So answer is going to be high dose folic acid 4 mg per day. High dose folic acid 4 mg. This is if there was no previous history. Right, so this is ruled out, not 1 mg, not mg is not high, 4 mg is high. You have to give 10x the dose, and there's no point of B12 supplementation. There's no point of B12 supplementation. So with this, we complete the discussion for this particular video, right? We'll discuss more questions and we'll discuss about what are the topics, right? In general, you can find out if you go through like, just the last 2-3 year papers also, right? And you make a list of the important topics, you still will do well in the next exam. Well, the questions definitely were a little higher in as far as the standard was concerned. If earlier the questions were easy, moderate, here now the questions probably were moderate to difficult. I would not deny that, right? But having said that, the question and the topics are being repeated again and again, right? Again, the PYQs are the key to cracking any exam. I keep on repeating it as far as NEET PG, NEET UG, and for that matter, NEET SS is concerned. If you're thorough with your previous year recalls of the last year, last year, and this year, and you map out a list of important topics and you ensure that you revise it before the exam, you will definitely do well. If you're anyone who's preparing for the NEET SS 2026, would advise you to take doc tutorials, the full plan with the videos, the elite test series, and the QBank. QBank, anyways, everyone knows the doc tutorials is the best one, but I would recommend you that even the videos, especially the elite videos and the QRP, will especially help you in revision just prior to the exam, right? So that's it from my side today. Thank you.